gonna hit record. There we go.
Hi, everybody. My name is Dr. Mary Claire Haver, and I am the creator and founder of the Galveston Diet. I'm also a board certified OB-GYN, and I am super excited to bring to you today Dr. Kelly Casperson. She is a board certified urologist and pelvic health expert, and I want to tell you a little bit more about her. Welcome, Kelly. I'm so glad to have you here. So Dr. Casperson is, her mission is to empower women to live their best life. She loves combining the power of mind, body, and relationships, and she joyously breaks down the social and societal barriers that are keeping us from awakening into our best intimate lives. Whether you are young or past menopause, single or in a long-term bond, it is never too late or early for you to realize you are not broken. With humor, candor, and ease, she breaks down the stories that we have been told about our sexuality to help us play, explore, and normalize our lives. So I met Dr. Casperson through a couple of groups that we belong to together with wellness and health and fitness, and watched her give the best talk on female sexuality that I have ever seen. Now, this is coming from a board certified OB-GYN who practiced for 20 years. And she gave such a beautiful, eloquent talk that touched me in so many levels, touched me personally as a wife, and as a lover, as a partner, touched me as a physician. And I thought, my goodness, if anyone had ever taught me how to say these things to patients, I would have been so much of a better physician. So I am so excited, Kelly, to have you on to share with the Galveston Diet followers your expertise and, kind of revamping. We've got lots of questions for you today. Where you're coming from and why your approach is so different. But first, tell us a little bit about your background, your training, medical school residency, those types of things.
Sure. Well, thank you for the great introduction. I've been a urologist now for 2012 is when I moved to the city. I finished residency in 2012. I'm going backwards. Urology is a 6-year training program, surgery, and it's specifically surgery of the kidneys, bladder, male genitalia was the definition at that point, but we've expanded since then. Medical school in Minnesota, undergrad in Minnesota, and I'm from a northern Minnesota town, about 80,000 people. And I think it's important for this discussion to say I was raised in a Catholic family and went to Catholic elementary school. So I did not come into my journey from my parents didn't get me here. So we'll say that. So when I was interviewing for urology residency, which is stereotypically male, there are now 8%. So that means 92% men are urologists in this country. So I was interviewing. Yeah, still right now board certified, we're at 8 to 10% women. About 30 to 40% are in residency if you look at the residency split. So it's going to happen, but it's still going to be a while. So I interviewed, and a female urologist was like, what fellowship do you want to do? You're going to need to do a fellowship so you don't have to see women. And that wasn't a cruel, in my experience, that wasn't a cruel thing. She wasn't being mean. That was just a fact of urologists don't want to see women. And it wasn't anything that I questioned. It was like, yeah, that's the fact, right? Women go to OB-GYNs and urologists deal with men. Mm-hmm. And only now that it's been years, I think back of that and I'm like, wow, I didn't even question that statement, right? And women were difficult. We didn't have answers. I remember going to a residency course on, I think it was erectile dysfunction, because Viagra has been around for decades. And they were like, we haven't figured out women. Women are challenging. Women are, difficult. They're too complex. And it was kind of this like compliment that wasn't like, oh, we're complex. That's why nobody's figured us out. And the more and more I learned, I'm like, women need help with this. This is universal. This is, and who's sleeping with the people we're giving Viagra to? Who's taking care of them, and who's taking care of their skin and their vulvas as menopause changes and hormones change, and all these women are just they're alone and they think they're the only one, and that is a universal statement. So fast forward, I'm in practice here doing general urology, and I had a patient who was a cancer survivor, and postmenopause. And she came in and she was just crying in my office because she wasn't intimate with her husband. They had a fantastic relationship, but sexual intimacy was gone. Crying in my office. And I just remember being like, I want to help her and I don't know how. And
so let me stop you for 1 second. So you were not really trained in your training program anything about.
No, do a fellowship so you really don't, because in urology, if you don't do a fellowship, more women will come to you because you haven't made yourself the oncologist, right? So no, there was no training. So I kind of came into it, and it kind of has turned into a passion project and made me realize how big this is. And now I'm connected with the sex therapist and the physical therapist, and like, it's a community, and it's really fun to work with people who care about this. Because it's a fun topic, because it's so big. And when you help people and they come back and they're like, I had sex and it wasn't painful, I'm having more sex and I'm actually enjoying it. You know, all these pieces is you're like, oh, that's a home run for me. Like, comedians go for the laugh, I go for the hugs. Like, that's what keeps me going.
So what percentage of your patient population would you say had some form of female sexual dysfunction?
Oh, well, once you start asking, it goes way, way up, right? Like, it's usually not what they come to you for, but then if you ask, you will find out it's huge. I mean, it's, oh God, probably 80%.
Yeah.
It's
So
huge.
for me, for the non-pregnant population, so, you know, as an OB-GYN, at least half of what I did was deliver babies, but then the other half was well woman care. And I was shocked getting out of training how many women, it was usually, okay, we're done. Okay, here's your prescriptions. We'll see you next year. And as I stood up to walk out of the room, it would be like, can I ask you one more thing? And they were so shy and timid. And I would sit back down and they would start talking about the difficulties they were having with desire or pain, or, you know, and the pain stuff I had been trained a little bit on, not much. But the desire, I had nothing. I had no tools to offer them. And I was literally a deer in the caught in the headlights. And the first 200 times that happened to me in my first year of practice, finally, I just, probably similar to you did, I started reading, and I went to the library and I went online and I researched on my own because I had nothing to offer these patients.
Yeah.
So
and I think the more and more, my first job when a woman brings this up is to normalize it, because everybody thinks that they're the only person and they're broken and it's a personality flaw. And to me, I'm like, you're normal. This is an everyday challenge. This is like, you know, the common cold of the pelvis. So, and just to normalize it, because women, there's a lot of shame involved. There's a lot of, well, I'm not where I want to be. There's something wrong with me. So the first thing I do is just talk about normalizing it. It's super common. This happens to probably everybody at some point in their life. Even if it's not now, it was earlier. If it's not now, it's going to be in the future, or it was right after the baby. There's phases where sex is not going well. So it's probably universal if you break it down like that.
can you talk about the different types of desire?
Yeah, so desire, they break it down, the scientists break it down into two types, which I didn't know. So there's two types of desire. There is spontaneous desire and there's reactive desire. And everybody thinks, because of our training in Hollywood, that spontaneous desire is what we're supposed to have at all times. Mm-hmm. And so that's where a lot of the feeling broken comes from, is to say, I'm not just desiring sex. I'm not just desiring to sleep with my husband. You know, I sit down on the couch and I want to sit down on the couch. I don't want to have sex. And normalizing that as we age, especially with hormone changes and or a long-term committed relationship, that reactive desire becomes the new normal. And there's nothing wrong with reactive desire. That's actually a normal phase of life. So reactive desire is, I wasn't thinking about sex. I wasn't seeking out sex, but the sexual situation has arisen and my partner's interested and I do things that put me in the mood, which is another topic. Like, how do you get in the mood? There are techniques to do this. So when the situation has presented itself, now you're interested in sex, you enjoy sex, and you have orgasm. So that's reactive. And then you say, so it's kind of like going to a party, right? You're like, I wasn't really thinking I wanted to party tonight. Like, my couch is comfy, I'm tired, I've got to work tomorrow. But if you bring yourself to the party, you're like, the music's good, there's tasty treats, boy, and I'd had great conversation. That was a fantastic party, but I wouldn't have gotten there if somebody didn't help me go. Right. So, and the other, just for analogies, as far as eating goes, there's spontaneous hunger and reactive hunger, right? So there, as far as desires within our body and kind of normalizing that sex is a lot like hunger, in saying, I'm spontaneously hungry right now, I'm going to seek out food. Versus reactive hunger is, I had a great meal, not really looking around, but oh my gosh, the dessert table just came by at the restaurant, I'm going to eat that dessert. So that's reactive hunger. So if we just think of like drives within our body and normalizing that there are two types for more things than just sex.
And as we age, the reactive form of desire tends to be, or I don't know many women in postmenopause who have any or a much spontaneous desire anymore.
Right. Yeah, and a lot of it is just
fine with it.
yeah, just educating women of being like, Hollywood is spontaneous desire, but that's not how our biologically our bodies work. So that's the number one reason that a woman goes to a physician is low libido. And I can, fix is the wrong word, but if I just reassure somebody to be like, do you enjoy sex? Is sex good for you? Do you orgasm? They're like, oh, it's great when I have it. I just don't want to spontaneously have it all the time. I'm like, there's nothing to fix them. That's reactive desire, and that's completely normal, and you're not broken.
So now let's talk about the women who can't even get to the reactive part because they're having pain, especially those in the menopause transition and postmenopausal.
Yeah. So pain is multifactorial, and it's really good to know if you have pain, it might not go away without you trying to solve it, right? Like you can't sit and wait for the pelvic pain to go away. And people will say, well, I don't desire sex because I have pain with sex. And it's like, well, that's just like everything else. I don't desire hitting my hand with a hammer because it hurts. Our bodies don't want to do things that are painful. So that's in working up low libido. Again, a woman comes to a doctor for low libido. Is it truly that you're not desiring sex, or the thing that you're supposed to be desiring causes you pain? So our brains don't desire painful things, right? So you have to fix the pain first before that desire can naturally come back.
So just in general, we're both physicians and we have to be very careful about practicing medicine on social media. But can you just kind of broadly touch on, and I know these as an OB-GYN, what are some over-the-counter and prescription treatments that a woman would consider if she is having dryness or pain or difficulty with intercourse?
Yeah. So I think about pain as far as the skin. So the skin needs to be addressed, and then the pelvis muscles or the orthopedic area. So I think of it as the pelvis and what is hurting in the pelvis. Very commonly perimenopausal, postmenopausal, and I'll loop in breastfeeding women with this, is really low hormones can lead to low testosterone, low estrogen. So the vulva and the skin gets very thinned and dry, and it's very just like our eye skin. It's just very tender and thin, and it's reactive. It really hurts. So the first easiest, simplest thing, if that's what a woman is thinking is going on, is you need to have lubrication for sex. So not all women and not all vaginas will lubricate properly for sex. I'm really interested in sex right now. I want to have sex, but my vagina is just not going to be comfortable for sex. Add a lubrication. The companies have done studies that 86% of Americans use lube. Lube is normal, and lube helps prevent friction and pain. So the first thing is kind of demystifying, like lube is there for the everyday common person to reduce friction, because friction hurts and you don't want to do things that hurt.
Are there certain types of lubricants like silicone-based or water-based that you lean towards, and what things in lubricants might you want to avoid?
Right. So I recommend avoiding all the gimmicky ones like strawberry and heat, the ones that heat. And because to me, I'm like, let's be clean, let's be simple, let's not put anything that our body might not like there, because if you start having kind of a reaction to a product, then you're not going to have sexy time. So I would just be like, make sure it has simple ingredients that you can understand. And then there's water-based and silicone-based are the most common. I always recommend silicone because it lasts longer. So if you just think about your skin cream, if it's water-based, you absorb it. So especially perimenopausal, postmenopausal breastfeeding, you don't want something that you put on dry, thirsty skin. It's going to be gone because your dry, thirsty skin is going to say, thank you, I needed that. And now you still are dry with sex. So silicone is really long lasting and doesn't get absorbed. So I recommend silicone lube.
Perfect. Now, what is a pelvic health therapist? When you started talking about, when you're starting to uncover the reasons women may have low libido and you're in this network, a lot of people don't realize that these type of people exist.
Yeah. The two people to know about is your pelvic floor physical therapist. So they're very important as far as pain goes. Even if a woman's not having pain, but her vagina might be tighter, they can help kind of work on exercises to stretch muscles and to help skin be comfortable. So they're really kind of the mechanical technicians of how do we get the pelvis to operate. So there's specialty training within physical therapy. Don't just go to a physical therapist down the street that you liked because he worked on your knee. Because I think not to overgeneralize, but they're just going to tell you to do Kegels. And that's not helpful. So somebody who's Herman and Wallace is a big company that does, and so you can go on to hermanandwallace.com and look for specially trained pelvic floor physical therapists. I have people, all over the country, and they're like, what do I do and you just go on that website and you can find people. So they have advanced training in the pelvis and pain. So that first people to know physical therapists. Second people to know about is sex therapists. So sex therapists, they're amazing, and there's not many of them. Because they're just like doctors, right? So these are therapists who went to therapy training school and then were like, I'm comfortable talking about sex. This is interesting to me. Whereas most therapists don't actually want to talk about sex, just like a lot of doctors, I would say, don't actually know how to talk about sex. So sex therapists are simply therapists who've now done advanced training to be comfortable talking about sexual dysfunction, sexual health, issues with your history and sex and the things you bring into your relationship. So they're wonderful, but I think there's not enough of them. So I kind of have my job's to break down the stigma of what a sex therapist is, because they work miracles for a lot of my patients.
So I think a good point to bring out here is what you said earlier, myself, and we've talked about this, offline, is we as experts in the area receive little to no training as far as sex and what to do in therapy, and how to talk to patients. And so I want to tell everyone out there watching and listening, don't expect a miracle when you go to your urologist or OB-GYN, because they probably weren't taught. And if they know anything, it's self-taught, or they went to a special class outside of their training. So, you may have gone to your doctor with these complaints. And I can remember getting out in private practice. This is now 20 years ago. And I went to my older white male partner and I said, I have all these patients who are having these, they don't want to have sex. I don't know what to tell them. And he said, just pat them on the leg and tell them to relax and maybe have some wine.
Yep. Have some wine. The classic one is have some wine. Well, so
I was like,
yeah, there's so many topics to
know any better.
Right. So a good question is, what does alcohol do to sex, right? So alcohol is a depressant, and alcohol decreases the ability to have orgasms. So alcohol is very good, however, for decreasing your inhibitions. And it's also very good. So what alcohol technically does is it makes you not think about the future, and it makes you think about right now. So it's very good at getting you in the moment to be like, oh yeah, that person, sexy time. Let's do it. I'm not worried about the presentation at work anymore. Alcohol is very good at that, but then you get into having sex and you're like, I'm not having orgasms. It actually inhibits sexual function, but it might get you to the party, but then the party is not going to be as good.
So like everything, a little bit of alcohol might go a long way, but too much
too much is not good. And I think doctors, I like to think they're not being harmful by saying that. Maybe they just think people are stressed, and that's as simple as sex is, but it's not. It's more complicated than that.
Right.
If you think for anything in life, if you think the answer is in a glass of wine, it's probably not.
So I've heard, and it's kind of a mantra. If you don't use it, you lose it. And so, there's lots and lots of ways to have sex. So when I say sex now, I'm talking about penis and vagina sex, like, and orgasms. What are your thoughts? What's the science behind the use it or lose it as far as penis and vagina sex?
It's a great question. It's less dramatic, and I'll preface my thing too. Stereotypically, I'm talking about a heterosexual female who has a vagina, who's sleeping with a man who has a penis. Those are my average patients, but that is not everybody, and I don't mean to exclude anybody. And I always feel like I need to say that to be wholehearted in this discussion. But so when most people talk about sex, they're talking about putting a penis in a vagina and a man having an orgasm that way and a woman having an orgasm that way. So that's the overview, but it's not that simple. So kind of controversial as far as should you just put more things in your vagina so your vagina is okay with having things in it, is really how I break that down. And again, I think it's well-meaning to be like, the science is, and there's not a lot of great science on this, but what I've seen is vaginas that aren't being used, whether they're having babies go through them or penises go through them or vibrators or whatever, is a vagina gets narrowed. The pelvic floor is a bowl of muscles and it gets narrowed. And same with skin, especially as it dries and tightens and thins with age, if it's not stretched and treated healthily, then it will stretch. When it stretches, it's going to hurt and crack. So there's absolutely something to that. The reason that some people think that that's a controversial statement is because it tells a woman that she should do something that might hurt and she should do it anyways, or she should do something that isn't pleasurable but she should do it anyways, and that really doesn't actually solve her problem. Mm-hmm. So it's a nuanced answer, like yes and no.
A family member of mine went through this, had a lot of pain after menopause and after hysterectomy, and was advised by her physician to have the Mona Lisa laser. And she's very upset because it was very expensive and she felt like it didn't do anything to help. Yeah. So that kind of came out after my training, and I was, of course, reps were coming by trying to sell us on it, but it's not anything I really know much about. Can you, educate our listeners about that?
That's a great topic. So vaginal lasers, there's lasers and radio frequency ablation, and the scientists and salesmen can get into that, but basically what it's trying to do and is vaginal rejuvenation, for lack of a better term. Now the FDA does not like that term, because the FDA says, what the heck is vaginal rejuvenation? And so I don't disagree with the FDA. But to kind of generalize it, the lasers and the ablation techniques is to kind of grow and stimulate more collagen and healthy skin. Mm-hmm. The science behind it is solid. Just like we remove acne scars, skin damage, tattoos, lasers do a lot of things to rejuvenate and regrow skin. So it's very natural that somebody said, people have skin problems in the vulva, let's design one that treats the vulva and the vagina. So totally get that. And I think it works great for that. I've seen excellent results. I've seen women having dry, painful sex. Now they're having comfortable, painless sex. The problem comes when you see somebody who sells you a laser who isn't getting into, I also have pain in my muscles. I also have low estrogen. I also have a relationship issue. So if you're bringing I tell my patients, if you think it's a magic wand, it's not a magic wand. And so if you go in saying, I'm going to get the Mona Lisa and it's going to fix my relationship issues, my low hormone issues, my desire issues, lasers don't fix desire. Lasers make your skin healthier. So it's great for the pelvis. So clearly I'm passionate about this because I'm like, it works great. But if you think it's going to solve everything, or you get it done by somebody who can't help you with everything else, so that's where you're going to get really frustrated.
Okay, that's a great answer.
That makes sense. So I love lasers. They work for the right problem. My medical advice, my strong opinion is, do not take platelets and get them injected in your clitoris.
Don't do it. My God. Stop it. People do that?
Oh yeah. That's a big thing. So Same thing of this is going to fix all my problems. There's no data, there's no science, and the people who
There's
are
no
doing it,
broken clitorises that I know of. I mean, unless you have diabetes and nerve damage.
there is no broken clitorises. So
There's broken partners.
yeah. So to me, lasers are expensive. Insurance doesn't care about sex. Insurance doesn't care about Viagra. So insurance doesn't care about the men. They're not going to care about the woman in the laser. So I get it, it's expensive, but if you're like, I have a bunch of money and I really want excellent skincare, laser is legitimate.
Mm-hmm.
But having somebody take your platelets, spin them out, inject them into your clitoris, and think it's going to do anything but empty your wallet, there's my strong opinion on that.
Good to know. All right, let's get back to talking about, someone in a, most of my patients were like yours as well. It's interesting though, where it was, a woman with a vagina and a man with a penis, and there's a mismatch in penis, vagina, desire, sex, whatever. Can you talk a little bit about that and the difference between same-sex partners?
Yeah. So orgasmic inequality. So in same-sex couples, specifically both penis, vagina, in same-sex couples, the individuals tend to have a much higher rate of orgasmic equality, around the lines of like 84%, which tells you even amongst same-sex individuals, the rate of being able to achieve orgasm is different for different people, right? We all have different hardware. But take that to two people, one has a penis and one has a vagina, the orgasmic inequality is staggering. It's on the order of like 20%, 20-80, let's call it. But so men and women in a relationship, they do not orgasm at the same percentage or the same amount. Mind-blowing. And why is that? Number one, society, whether we've thought about it or not, values the male orgasm more than it values the female orgasm.
Of course.
So there's that. And in a woman's training is my job and I'm desirable because of my ability to give a man an orgasm. So there's a lot of kind of that desire thing wrapped up, and her success as a sexual partner is to give him an orgasm. Guys aren't the same way. They're more trained to be like, I'm gonna have an orgasm, right? But are we teaching our teenage girls that? Like, your desire is important and your desire should be equal to your partner's desire.
Yeah. And against every societal norm I was brought up with.
Yeah, which is why
Catholic, if you ever even think about desire, then you are basically a prostitute.
Yes, and then you wonder why women don't have desire or have desire issues. Mm-hmm. Part of this is the biggest. Yesterday I was talking to a woman and I'm like, we have to work on your biggest sex organ, and I'm pointing to my forehead and she's like, my forehead, and I'm like, no, your brain. But yeah, if you've been told that you're shameful and bad if you have pleasure, you're gonna have you might have trouble achieving orgasm.
So what percentage of women have orgasm? I know this because I'm a doctor, but I had to no one said this out loud in a lecture. What percent of women have orgasm with normal penis and vagina intercourse? 20%
at best. Those are the optimistic studies, and the theory is so everybody's different. We all have different equipment, and the clitoris and the vaginal opening are different lengths in different pelvises. Mm-hmm. So the thought is, because some women will say, I have great orgasms with PIV sex. Well, her clitoris might actually be closer to her vagina, so she's getting a lot. The theory being she's still requiring the clitoral stimulation, but it's just closer to the vagina. So penis and vagina. Anatomy issue, right? So the clitoris is our pleasure organ, but nobody is taught that. And so for women that's the other normalizing thing, which is so cool. A woman comes in and she's like, her goal is to have an orgasm with the penis in the vagina. And I have to say, the data doesn't support that that's a realistic goal. And so just reframing it and normalizing it and being like, oh, you don't have an orgasm when the penis is in your vagina? That means you're normal.
That means normal. The other people are pretty.
Yeah. So, a lot of it's just reframing and education and helping women feel that you're actually having a normal experience. Now that said, you desire orgasm. Let's talk about ways to get you there. But you have to bring the clitoris into the, I hate absolutes, but yeah, you pretty much have to bring the clitoris into the party.
So let's talk a little bit about vaginal estrogen. I'm very passionate about this as well. You know, that was the one tool that I do have. You know, again, we can't give out medical advice, but so can you give your broad kind of umbrella talk about vaginal estrogen?
Yeah. So going back, my short answer for people who just want short answers: vaginal estrogen is good. The risk of cancer is 0. And I just think everybody should be on vaginal estrogen probably after the age of 45. Now that's my put it on a billboard statement. And it's more nuanced than that. But vaginal estrogen is excellent. So embryologically, the vulva becomes the vulva because it's seeing hormones, right? It's seeing testosterone and it's seeing estrogen, and those cells are saying, I'm going to be a healthy vulva. So that's how it works. So what happens after menopause, and it really accelerates about 10 years after menopause, we really start seeing the atrophic vaginitis about 10 years after menopause, is the hormones go away. And so the little organ that said, but this is what I needed to be me, doesn't have those signals anymore. So what all vaginal estrogen does is put back the signals that made a healthy vulva a healthy vulva. That's it. So what does that do? It makes the skin more moist. So lubrication is good for sex. It makes the skin thicker so that it's less sensitive to trauma. So sex doesn't hurt as much. So it works great because it's not doing anything that the vulva didn't already have for 40 years of your life.
Just giving you back what you had.
Just giving it back.
I used to tell patients, you know, when you look at a microscopic section of a pre and postmenopausal vagina, you know, with healthy estrogen and with no estrogen, the premenopausal vagina is this gorgeous, velvety, multi-layered, lots of these like globules just oozing out natural lubrication. And then you look at the postmenopausal vagina and it's flattened. It looks like a desert. I mean, it's just dry, flat. The tissues are all squished. There's no moist, you know, it's night and day. And we can get you back to this with just a little medicine in the vagina. That's very, very safe.
It's very, very safe. So multiple studies have been done on looking at the safety of vaginal estrogen because everybody cares greatly about not harming women. So there's a lot of data on this, and the fear of cancer in women, then they come to my office, everybody's freaked of cancer. But what society's told them is that estrogen causes cancer. That's a simple news clip. But vaginal estrogen does not cause cancer. And I always say this, this is the number of the chance of cancer with vaginal estrogen. And they're like, 0? And I'm like, yes, 0. And if you're okay with that risk, which everybody should be, you know, and then it's also a nice time to talk about cancer risk, right? To be like, your vaginal estrogen risk for cancer is 0. Let's talk about your smoking. Let's talk about the fact you don't exercise and the fact that you're not making wise food choices.
Right.
Because the risk of cancer with those choices is actually quite high.
Much higher.
So, much higher. I love data, and that stuff kind of gets fun because you're like, oh, your vaginal estrogen is not gonna be the thing that did it. Let's not fear it. Let's make once I started breaking it down, saying it's skincare, it's just skincare. We want healthy, glowing skin that looks youthful and feels good. Yeah, right. So this is that vaginal estrogen is vulva skincare. Works great.
So
prescription because it's a hormone.
Premarin can be expensive. What are some alternatives? Premarin is the cream, and there's no generic.
Right. So estradiol, which is estrase. So those are the non-conjugated equine estrogens. So the non-premarins are brand name and generic. The generic is still pricey. That's going to take another while.
A woman in the FDA.
Yeah. So it is generic, but that doesn't always mean it's cheaper at this point. Compounded medications are an option. That said, the amount, when I talk to patients, the estrogen tube is big. It's a big tube. So people will be like, oh, it's $150. And I'm like, great, for 6 months of skincare? month by month, it's actually not that expensive. So now that said, I tend to underdose because I don't think people, if they use the amount that is prescribed, it's really messy, and they don't like messy vaginas. Nobody likes messy vaginas. So, we use a lot less amount just because it's not annoyingly messy. And then that tube will last you a long time. So that's my other talk of like, if it causes you to not have pain with sex, or you're having more sex and it lasts you 6 months, it's probably worth the cost.
Right.
If it's still too much, look into compounding, because compounding can be cheaper, but insurance doesn't cover compounded medication.
All right. So what's your takeaway here? We're going to wrap this up. Top 3 things to tell a woman who has desire mismatch, who wants to have more sex, but can't figure out how to get there.
Yep. The most important thing is you are in charge. It's and education's out there. You just have to find the right resources. And even just reading a couple of the books, or watching videos like this is so normalizing to people to realize, like, this is not my problem. This is not my personality flaw. This is the hardware that God gave me, and reactive desire is the totally normal thing that happens when we're not 18 and not matched up with a long-term partner. So that is reactive desire is the normal. Not having an orgasm with penis and vagina is the normal. And then my third takeaway is pleasure is the goal. When it comes down to whatever question you're going to ask, this comes down to pleasure, and pleasure is the goal. The orgasm is a pleasurable experience, and we are all worthy of achieving satisfaction and pleasure. And at the end of the day, that's the goal.
Since there's typically another person involved in this conversation, the partner, how, some women are terrified, or they don't know how to begin to talk to their partners. What would you recommend?
Yeah. So it's do's and don'ts for this conversation. So the don'ts: don't talk about sex right when you guys are going to go have sex. Don't talk about better sex right after you guys had sex. Like, you have to have the right situation. Don't throw the sex life that you want changed when you're already in an argument about something else. So there are places and times for wanting to talk to a man about sex, and so those would be the places to avoid. Also understand, kind of, not to segue too much, but as much as society has taught us incorrectly about sex, they've also done a very good job of teaching men incorrectly about sex. And so they're not the experts that are the enlightened beings, and we shouldn't think that they are. They have just as much misconceptions about how a woman has an orgasm, misconceptions of they're broken if their penis doesn't work well, or their manliness is gone. Like, that's a very stressful thing for a man to be told that you're not enough, right? So it's a very sensitive topic, and men have it just as many issues as women do in this society and sex. So bringing it, so those are the don'ts, and the respect who you're talking to, because they didn't get great sex education either, right? And they might need to learn with you. So yeah, talk, when you frame it, talk about it as being about you, right? I'm looking into, I really love having orgasms and feeling close with you, and I'd like to do it more, but I don't know how to. And I would love if we could work on this together.
Awesome.
So what that did is it said, this is me. This is my project. I love being with you, and can we work together?
Awesome.
Right. So.
All right. Well, this was amazing. Thank you so much. I'll put in the comments what your Facebook group is.
Yep. We're starting a Facebook group.
It's going to be launching soon.
Yep.
Yeah. And thank you so much for coming on. This was so much fun.
My pleasure. Thanks for having me.
Take care.